us that we are allowed to provide 1.0 contact hour for today. And that 1.0 contact hour we've written in such a way that today is an ethics CEU for you all who are participating. So that's perhaps good news for you. In order to receive a credit for us, a certificate, you must do our evaluation. And in order to do our evaluation, you must go to a link and have a password. It is password protected. And we do that in order to show to the Alabama Board of Social Work that this hour is a live hour. And I'm sorry, I'm getting caught up in some of the controls here and letting people in. Now, you must complete the certificate. It is password protected, and we give the evaluation at the end. The link that you must have, and I'll give it now and I'll give it again at the end, is https colon // www.surveymonkey.com /lowercase r / all uppercase letters D as in dog, G as in girl, W, X, P as in Paul, F as in Frank, X. That's our link today. The evaluation will stay open until 8 o'clock. I'll give the password at the end, and nurses will be uploading your hours within the week. Everyone who does an evaluation will get a certificate, and no one who doesn't do an evaluation will get a certificate. So that is posted now in the chat room for you. And we do encourage discussion. And I hope that today you will feel confident about talking a lot. I'm depending on discussion for today's topic. Again, it is an ethics topic, it is navigating diversity, a comprehensive guide to cultural intelligence, or CQ. And I'm hoping that you'll participate. If you're new to Zoom and you're not sure how to access the chat room, move your cursor up to the top of your screen and a bar should appear with the word chat on it. If that doesn't happen, move your cursor down to the bottom of your screen where the word chat will appear on a bar, and join your voice to mine. I know that we'll all be enriched if you add your voice to mine, your experience, your observations, your outcomes. Our objectives for today are threefold. One is we want to define and analyze the four pillars of cultural intelligence, or CQ, and their application. Two, we hope to show and evaluate the ethical mandates regarding accountability and cultural humility. And we also, screen sharing is still paused. Thank you for letting me know that. How do I unpause it? Share. That is curious. I've never had this happen. I apologize, y'all. Let me stop the share, try to share it again, and I apologize for that. I was going through our objectives as I was speaking, and let's see. Okay, it appears that I'm screen sharing now. I hope that's the case. Please let me know if it's not. Our third objective is to apply 10 research-based communication strategies Three new. Yes, sir, it's on. Thank you. Yeah, thank you all. Again, thank you for discussing and interacting. That really makes this presentation much more enjoyable. Let me ask y'all then, when a patient is silent as you explain their treatment plan, what are your impressions of that patient or that encounter? So when a patient is silent as you explain their treatment plan, what are your impressions of that patient? Please share in the chat room. We'd love to see they are processing the information that is more than likely new to them. Thank you, Ms. Hurd. That's a good thing to jump to. They're either listening and processing or not understanding, Ms. Caddis. Thank you. They're probably overwhelmed by the information and need it broken down further. They are processing it, or they don't understand and need the opportunity to ask questions. Thank you, Miss Loy. Thank you all for joining in the chat. It depends, says Miss Sims. Sometimes they may be taking in the info. Other times they may be thinking if there's more they want to add. They may not be able to hear you, says Miss Smith. I agree. Processing information, Miss Patton. Thank you all so much. Thank you all for joining in. Well, let's define cultural intelligence. Cultural intelligence, or CQ, is someone's ability to function and manage in culturally diverse settings. In fact, CQ is the missing link between simply being aware of a cultural difference and showing real competence in meeting that. The real world impact might be that in Alabama, we might prevent a patient or might understand a patient's cultural silence as a lack of intelligence or engagement, when in fact it could be so much many more things, as you all have alluded to. And so you've already shown here that you're using cultural intelligence. Let's talk about the four pillars of cultural intelligence, the four pillars of CQ. We said we would address these in the beginning. It's on the evaluation. And also on the evaluation, I do ask if you have topics that are important to you that you'd like to see us try to address, please list those. It helps so much to know that the content that we're delivering is what you want. So the four pillars of CQ, first is drive, your motivation. So this would be, for example, a social worker who spends their free time learning Spanish in order to meet the ever-growing Latino population that they're seeing in their practice. So this is a clear example of motivation. It's drive, it's taking initiative. Then we would look at our knowledge. So the second pillar of cultural intelligence is our knowledge base, and we all come with that. So that would be a nurse practitioner, for example, understanding the religious restrictions of a Jehovah's Witness as she is discussing surgery prep with them. So that's knowledge. We understand that Jehovah's Witnesses have certain feelings about blood transfusions. Then there's strategy, and this is metacognition. So this is beyond thinking in a sense. So this might be if a leader was sitting in a boardroom or in a meeting room and everyone was touting the new patient portal, the leader might pause to ask, but what about those people who don't have internet access? What are we doing for them? Are we excluding them? So that's showing metacognition. That's showing strategy. That's the third pillar of cultural intelligence. And the fourth pillar is action. So it's taking the first three and having our behavior then modified to incorporate those. So it would be, for example, a case manager who is normally used to bullet pointing, and so to speak, information about a treatment plan, stopping and understanding the verbal cues and the silence as a possible misunderstanding and changing their style of communication to storytelling, for example, to better accommodate that person's culture, in which messages are often suggested rather than directly stated. So that would be action. So the four pillars are drive or motivation, knowledge, your cognition, strategy, your metacognition, and action, your behavior. So let's look at drive. Drive is the motivational core of the four pillars. It is, in fact, having an intrinsic interest in people, in wanting to know people who are different from us. And it also involves, drive involves a self efficacy, which is simply the confidence that you can meet a cultural situation that's complex and adapt and correctly meet it. It's confidence. And so, without drive, if you didn't have drive, you might be loath to have certain difficult conversations. And unfortunately, not having these difficult conversations can lead to systemic exclusion and, more importantly, ethical failure in patient advocacy. And so here's a tip how you might develop drive. You might reflect on the tangible benefits of taking an interest in asking those questions. And you might see that the benefit would be fewer clinical errors and a higher patient satisfaction and possibly even better team morale. So, drive is the motivational core. Have you ever had a patient whose accent you could not understand? How did you handle the situation? Have you ever had a patient whose accent you could not understand? How did you handle the situation? Have you ever had? Yes, I got a colleague to help me, worked with a coworker to aid in determining what the patient was saying. That's great. So, our second pillar is our knowledge or our cognitive base, our cultural intelligence. Interpreter services if needed. Yes, ask for a family member to help interpret if patient client was okay with that happening. We'll talk about that, Ms. Hurd. Use the interpreter surfaces. Thank you. So we have to in Alabama understand some macro cultural systems. I think anyone who has worked here for any time understands that there is an interplay between faith and family hierarchies and trust in the healthcare system. There's a large population in Alabama that does not trust the healthcare system. And so we have to be aware, knowledgeable of the socioeconomic barriers that different patients and clients present. And this could affect everything from transport to and from a doctor or the ability to pay for medications and so on and so forth. And we also have to understand religious fasting periods because there are different Christian denominations who fast in our area, in addition to those who have moved in who profess Islam as a faith. And then, as I had asked earlier, there are regional Alabama dialects or communication norms that particularly if you work in a rural area, that you have to adapt to. And that is your knowledge base. That's the second pillar of CQ knowledge, of CQ, of cultural intelligence, excuse me. Ms. Cronin says, I'm not a clinician, but in our social services agency, we have used interpreter service or Google Translate to bridge the gap. That's fascinating, Google Translate. Have y'all, anyone, have you ever had a patient who seemed to avoid encounters? What were your impressions? How did you handle it? Have you ever had a patient who seemed to avoid encounters? What were your impressions in that instance, and how did you handle the situation? Try to build rapport before getting into too many details about diagnosis, Miss Langford. Thank you. Anyone else? Have you ever had a patient who seemed to avoid encounters? How did you handle the situation? Please share with all of us here in the chat room. Family member thinks physicians are out to get money. Educate, 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 says Miss Fonstock. That's exactly where we're going. Yes, tried to meet them. Oh, I don't want to lose these. They're so good. Yes, tried to get to meet them where they were and used incentives, Miss Sims. He loved Pepsi, so I would get him before session. Miss Bird, helping the patient feel comfortable by letting them know about confidentiality and safe space. Miss Hurd, ask them what they might need in that moment. Miss Langford, educate on expectations related to treatment. Explain it in easy to understand terms. Ms. Smith, I agree with Belinda. Building rapport can bridge many gaps before getting down to the hard topics. Those are great responses. Strategy, the third pillar, thinking about thinking. This is what y'all, I think, did in these situations. You planned, monitored, you reviewed, you applied your knowledge and drive, and you anticipated the needs of these clients before their visit. You monitored the cues during intake. This was part of building rapport, understanding you couldn't launch into the diagnosis straight away, and then checking with yourself post encounter. Hey, how did I do? Did I meet them where they were, as someone so eloquently put? So here is an example. A social worker realizes that their client is avoiding a home visit. So, just like one of our respondents using strategy, she hypothesized, or they hypothesized, a fear of authorities, and they planned a neutral site meeting instead. And they may have even bought a Pepsi. So, they ensured welfare without triggering trauma. And this fulfills, whomever said this, the NSAW mandate of service. So again, we are fulfilling the ethical demand of service. And then action. The fourth pillar is flexible behavior. So action is about modification. It's about modifying verbal and nonverbal cues. If you know, for example, that a culture values being addressed as Mr. or Mrs. and not by their first names, then addressing them as Mr. or Mrs. is a high and vital, culturally intelligent action. Here's a clinical detail for you. Adapting your touch, in fact, asking before physical assessment, is not only high cultural intelligence, but is also an ethical requirement for patient dignity. And so I want to ask y'all then, why does exhibiting and promoting a high CQ matter? Why does exhibiting and promoting high cultural intelligence matter, or does it matter? Respect, says Keldon Jones. I like that. Why does exhibiting and promoting high CQ matter? Well, for one thing, if you are a nurse and you are bound by your ethical code surrounding diversity and integrity, you are individually responsible and accountable for quality care and safety. And the culturally intelligent application here would be preventing any errors that you might make from assumptions around cultural bias. And in terms of the integrity standard, which is simply moral and professional honesty, you might then, as that same nurse, then disclose in your reporting any potential cultural bias. And as concerns the standard of diversity, you would be valuing individual differences, which is the core focus of cultural intelligence mastery. It is, in a sense, just valuing and understanding that people are unique and individual. Ms. Sims says it makes our patients more comfortable, and when they are more comfortable, they are likely more trusting. Therefore, treatment is going to go much better for the patient, which is what we want for them. Ms. Henderson says it allows equity. Ms. Fonstock says it provides information for them to make their own decision, and it helps them maintain their dignity. Now, as concerns social work, the Alabama Board of Social Work Examiners adopts the NASW code, and standard 1.05 mandates that social workers should demonstrate understanding of culture and its function in human behavior and society, which is essentially this: putting humility over competence. In other words, instead of thinking yourself to be an expert in culturally sensitive issues or topics or intelligent issues, shift your paradigm instead to think of yourself as a learner in each cultural relationship. And in that way, you will be practicing high cultural intelligence. Now, the other, excuse me, doggone it, pardon me, y'all. So, ethical standard 4.02 for social workers in discrimination, social workers should not practice, condone, facilitate, or collaborate with any form of discrimination on the basis of race, ethnicity, or disability. This also includes institutional discrimination. So if you oversee a clinic and you see biased referral patterns, employing high cultural intelligence and strategy would force you to want to audit those patterns and enforce ethical compliance. In short, you as nurses and social workers, clinicians and administrators, you are 100% responsible for the equity of the care that you provide. Cultural incompetence, therefore, is a professional deficit. And that professional deficit can lead to ethical violations and violations that occur and affect patient safety as well as social justice. So, why does cultural intelligence matter? That's why. Well, then, if it matters, if you agree with me, how might we begin to implement some strategies then to develop a high cultural intelligence? How might we begin to develop some strategies? And the fact of the matter is, you possess all of these, and they're quite simple to address. But again, it requires drive. Strategies 1 through 3 involve the cognitive foundations, the pillar, and that involves context. So we want to recognize when we're in high context situations, which we can find ourselves in certain cultures in Alabama, versus low context and explicit normal situations. We want to practice active listening. We all know this. How many times have you been told to listen for the emotion in the words and look for or listen for, in a sense, the unspoken? And one way to activate this is to summarize often what folks are saying. And then thirdly, we want to simplify. Someone earlier said, and I congratulated them, that they removed jargon and idioms. And so they simplified. And Ms. Hurd said, reflective listening. You've already got it. See, y'all are so smart. So strategies 4 through 6 affect the interpersonal presence that we're providing. And so y'all may know this, but 80% of communication is eye contact, posture, and proxemics. And if proxemics is a new word to you, proxemics is simply a study or a recognition of the space between us. You know, if you've ever had this notion that someone was in your space, well, they were violating the law of proxemics, of good proxemics. Patience, which someone has also said so nicely today, that you build over time. So you build over minutes and visits, not seconds or initial intake, even. And you never rush your intake. Patience is more than a virtue when it comes to care. And training. So ongoing simulations, if you can bring these about in your workplace, of dealing with folks who are from culturally sensitive or different arenas from that you normally practice with. If you can do live simulations, they're much more effective than passive videos or passive trainings like today's. And then strategies 7 through 10, these empower us. So, one, we can use visual aids. We can use pictograms and diagrams, the pain scale, for example, to bridge language gaps. We can ask for feedback. Someone said that, reflective listening. Ask for feedback and verify that the meaning of what we were explaining was both received and preserved. Empathy, seeing through their so-called identity lens, which is understanding their unique struggle. Again, we're talking about the uniqueness of individuals. This is what cultural intelligence recognizes. And then lastly, adaptation, which is changing your behavior to achieve the goal of engaging in high cultural intelligence. So I'll ask y'all, I think y'all know your answer, but do you think it's reasonable to think that teams with a high CQ provide better care? Is it reasonable to think that teams with a high cultural intelligence factor provide better care? Yes or no? Yes, Miss Smith, absolutely yes. Thumbs up. It is reasonable. Yes, 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 it is. It's reasonable. In fact, it's been proven. There's research by, and I hope I'm pronouncing the name correctly, Ang or Ong and Van Dyne, and they indicated that when a team is diverse, the team itself is diverse, but lacks cultural intelligence, then the performance often drops below that of a so-called homogeneous team, where the team members are all pretty much alike. And this is due to process losses that occur from misunderstandings and frictions and hidden biases that tend to create an us versus them mentality. And when this happens, this is a major ethical concern in nursing and social work. Now, the homogeneous teams that they studied had a baseline of 65% efficiency, and this was initially because they were homogeneous. They shared a common language, a common culture, common social norms, and they were also prone to groupthink. And the issue then is that when they were introduced to complex situations, they lacked innovation because they were stuck in how we've always done it, how we always do it, how we know we do it. But the diverse teams that employed high cultural intelligence had a 92% effectiveness rating based on what they termed, Ang and Van Dyne, the diversity dividend. And their research shows that when cultural intelligence, and specifically strategy and action, are applied, the friction of diversity within the team is converted into a catalyst for innovation. And in healthcare, this showed by manifesting as higher patient safety scores and more accurate diagnoses across diverse populations. The Joint Commission's landmark study entitled Advancing Effective Communication, Cultural Competence, and Patient and Family Centered Care found that hospitals that showed high cultural competence saw a significant reduction in adverse events. And the research that they did indicated that communication failures, again, maybe prone to the us versus them mentality, were the root cause of over 60% of sentinel events. So, you have a patient who refuses daytime insulin during Ramadan. The nurse labels the patient as non-compliant. What is the high CQ response? Please share in the chat room. We've introduced you to the concept. You already possess it within you, and this may be redundant information, and if so, I apologize. But a patient refuses daytime insulin during Ramadan. The nurse labels them as non-compliant. What is the high CQ response? The patient refuses daytime insulin during Ramadan. The nurse labels them non-compliant. What is the high CQ response? Well, the high CQ, they aren't non-compliant, says Ms. Smith. They have every right to refuse, and the nurse should return after that period. Care plan for that time frame. That's a good idea. What this manager might do is simply adjust the dosage times to sunset. This would respect both the dignity of this practitioner and it would ensure that they are compliant and that it is safe. Ms. Sims says to ask why it is important to them they not take the insulin during the day because of Ramadan and see if there's a better time to see when they can take it. Very good. And Regina Petreca, who's new to our chat room, thank you. The nurse needs education. Ask them to remove the oh, sorry, it clicked up. Ask them to remove the label and adjust approach. Nurse needs to discuss with the patient and provider to alter the plan of care. Yes. Thank y'all. See, you already possess this, which you probably already knew. A rural family refuses a home visit. Caseworker assumes they are hiding abuse. What is the high CQ response? A rural family refuses a home visit. The caseworker assumes that they are hiding potential abuse. What is the high CQ response? Someone actually has already discussed it earlier. A rural family refuses a home visit. The caseworker assumes they are hiding abuse. What is the high CQ response? Well, just as our participant had stated earlier, she looked to understand and discover that the family has a deep distrust of government vehicles. So instead, she suggests they meet at a local park. And in that way, and as discussed earlier, she fostered trust with them. And more importantly, or equally important, she satisfied the service mandate that is an ethical standard for her. Let's look at some actionable tools to help you. excuse me, community mapping. So you probably have done this as clinicians, but we want to identify those gatekeepers, the pastors, the barbers, the realtors, anyone, local shop owners who act as bridges to the community. And if you can formalize these partnerships in some way, you can then reach those underserved citizens. In terms of language and not understanding an accent or not understanding a language, what we're suggesting is that we ban, unfortunately, as someone had replied earlier, that we ban the use of family members as interpreters. For one thing, this is an ethical risk. And for another, in order to adhere to Title VI of the Civil Rights Act, we must provide certified medical interpretation to ensure that true informed consent is received. Now, I would be interested to know, and so might you, whether Google Interpreter would be considered as a certified medical interpreter, but I should think it would. And then, if you are in such a position, do an equity audit, review your referral rates and wait times for disparities, and look at the fact that you're doing data driven correction. This is the hallmark of a professional accountability standard. Let's see. Speaking on the previous case example, says Miss Loy, it's so dangerous to just assume anything about people. That alone is bias we are bringing into a patient situation before we've even assessed it. They're so right. You're so right. So let's look at some more actionable tools. Here's a communication quick reference. Now, when I talk about high context cultures, do you know what I'm talking about? These are might be Asian cultures or Middle Eastern cultures, and certainly some traditional Southern cultures, in which they tend to rely more on physical context and shared history and nonverbal cues, and not necessarily the spoken word. And so you have to learn then, if you're dealing with someone, as we talked earlier, and interpret their silence either as a sign of respect and adherence or as a sign of disagreement, and adjust accordingly. So the recommended action when dealing with folks from this culture are to wait for their silence and then look for their nonverbal agreement. Silence can often be a sign of respect. It can be a sign of contemplation, as someone said earlier, or a sign that they're not going to do what you're saying. And then why do we do this? Well, it's respecting personhood. This aligns with the ABN's value of dignity. If a nurse were to rush a patient or interpret their silence as compliance, that nurse would be failing to respect that patient's individual personhood and autonomy. Here's someone who says, I would not use Google Translate in a hospital setting due to HIPAA Act, as well as the potential to misinterpretation. Very well. I didn't. I spoke without thinking. You're right. Google Translate works well for my office because it is only used when our immigration specialist is out of our office. Thank you for clarifying that point. Thank you so much. Here's a quick reference. When you have a language gap, the recommended and reasonable and Title VI thing to do is to have some sort of certified interpreter, and this requires you to pause until such interpreter can be made available to ensure that the clinical data is accurate and that informed consent takes place. Now, in conflict resolution, this is a team and morale as well as a patient ethic. If we are addressing a performance issue or a clinical disagreement, and we're talking with someone who comes from a culture that very much values face and saving face and having respect and being shown respect, then we want to correct privately, and we want to correct in such a way that what we're suggesting is a process improvement for us all and not an individual failure, and certainly not doing so in any way that would shame the person in front of their peers after the fact when things change. So this satisfies both ABN and ABSWE standards for professionalism. And it shows ethical reasoning, integrity, and professionalism. So it requires that you maintain the integrity of the professional with whom you are working and allow them to save face. And why do you do this? Because it builds trust. Remember, trust is built over a long time. And that trust is necessary for collaboration in the future. And if that collaboration is not allowed to take place due to a perceived public shaming, then what we will see in its place is a permanent breakdown in care delivery. Cultural intelligence from the identity lens is the bridge between clinical competence and moral excellence. It is the silent engine of ethical care, so stated the Alabama Leadership Summit in 2024. And I think what we can leave today with, and this is a short CEU, y'all, I do apologize. Perhaps we can discuss some things for a few minutes. Clinicians in Alabama have a unique role, you know this, in bridging divides. Cultural intelligence is the tool that will allow you to fulfill that promise of justice and dignity for all of the people you serve. Our CEU code word is CQ. I am putting the link and the password into the chat. Here is here's the password. https://www.surveymonkey.com/r lowercase all uppercase letters, D as in dog, G as in girl, W X, P as in Paul, F as in Frank, X. That's our link, and our password is CQ. CQ, capital C, capital Q is the password. Does anyone have anything they'd like to add today? I can unmute you if you like, or we can end our session. We'll be back on Tuesday, June the 30th. So we're missing most of June. I hope that you all have a wonderful June. I hope that you appreciate getting an ethics certificate today, given that the course ran short. Thank you, Ms. Hurd. Thank you, Ms. Hunter. Great comments from the group. I agree. Thank y'all. Thank you, Ms. Sims, Ms. Petrecka. Thank you, Mr. Leslie. Thank y'all so much. Hope y'all have a wonderful month of June, and look for us back on June 30th. We'll be presenting case studies from Care Navigation, so talking about what I do. So if anyone's interested in that, you may find that our next presentation is for you. You can register for it when you do the evaluation, for which the password is CQ. Wondering how. Okay. Thank y'all so much for being here. Thank you for all you do, and take great care of yourselves. See you at the end of June.